Hi everyone, happy Tuesday. I hope you guys are having a good start to the day. I wanted to do a video today just discussing some statistics, some data, some medical studies that have been out there just to help you understand some of the numbers and how complex this situation really is. I do want to say thank you so much for all of the kind responses that have been sent my way. It's hard to put your face out there, and there has been so much positive feedback, but sometimes you do get pulled down into the negative comments, and I just have to remind myself that a lot of you have started to look at me for information and guidance as to this entire coronavirus situation, which is why I continue to make these videos for you. So before I start, I do have one request, and that is to just keep all of the comments civil. Speak to one another as though you are speaking face to face and not hiding behind our cell phone screens. We are all allowed to have different opinions and state them freely. And of course, our own personal experiences, our networks, our social media feeds, who and what we choose to listen to will all affect how we feel about this virus. But the last time I checked, calling someone a freaking idiot won't kill the virus, and it also is not going to reopen the economy. So let's continue to be kind to one another, regardless of having a difference in opinion. So, and just like you guys, I'm tired, I am frustrated, I am definitely looking for better days ahead, and I believe they're coming. I really do, and I hope that you do as well. So, first I want to talk a little bit about numbers and statistics. I am not going to use the numbers in Kern County because I'm sure that you guys can understand that one county in California that has 900,000 people is simply not enough to allow the state to change its behavior when our state, California, has 39 million people in it. We have to go to a bigger scale. And I understand that it's frustrating for those in Kern County because our numbers have been relatively low, and yet we continue to have to shelter in place. But this, again, is not, Kern County is not necessarily reflective of what's happening in the state, and certainly not reflective of what's happening in the country. We've got to go to a larger scale, at least when we're starting to talk about numbers and percentages and statistics, because we all know that sample size is important. And I think that you guys all can understand how it is incorrect from a statistical standpoint to take the number of positive tests in the US and consider that fair and equal to the number of people in the US who truly have COVID-19. So if we say that 19.6% of US citizens who have had a positive COVID-19 test, that doesn't mean that 19.6% of all US citizens have had COVID-19, because that would be 64 million people. We're just not allowed to make that extrapolation until we conduct random sampling. And thus far, the tests that we have run have been for those who have gone to seek medical care, and it's a sampling bias. So again, we can't make that assumption that the number of positive tests in a region equals the total number of people in that region that have the disease or this virus. Similarly, an accurate mortality rate cannot be calculated by taking sort of this inaccurate determination of how many people have COVID-19 in the US and divided by the number of people who have died from COVID-19. It's simply not that straightforward. It's not just a simple division and multiplication equation. And so to further discuss the complexity of this issue, let's talk about each of those, the numerator and the denominator. There are studies that are being done to help us better identify the denominator. And we're actually going to look at one in depth, and the denominator being the number of people that actually have had this virus. The numerator is the number of deaths. And quite honestly, this data is also shaky. It certainly doesn't include those who died at home in New York City, in New Orleans, in Detroit. And yes, I understand that there are probably nil to zero who have died in their home in California. But again, this is a pandemic. It is a global issue. And so we're looking at larger population sizes. But also, our current data does not include the 835,000 individuals who have not yet died, but who have not yet recovered and have had a positive test. And when you're looking at good science, you can't simply assume that all 835,000 of those individuals lived, right? We need to actually know what happened. And quite honestly, that's not going to be feasible. We're not going to know what happened to all 835,000 of those individuals. So let's go into that a little bit more. A little bit older data, but as of April 16th, only 17% of COVID cases had officially recovered or died, and we don't know the outcome of 83% of those cases. And again, we need to know that outcome. Are we going to be able to have that data for sure? Probably not. But can we assume that all 83% survived? Probably not. Other people are arguing that doctors are falsifying the cause of death, saying that, if you got in a car accident but you were COVID-19 positive, that you died of COVID-19. Again, we're trying to talk about facts and data and proof. And unless we are actually signing the death certificates ourselves, unless we are watching someone else sign the death certificate, or we have been involved directly in that person's care who died with or without COVID-19, isn't that all hearsay? And I thought we're trying to stick with the facts, right? So we shouldn't be speculating on what doctors are doing unless we truly know what they are doing. And for example, with an individual who dies in a car accident, I think the first responders and the doctors who take care of this particular individual will have a better idea of what happened. Maybe he had COVID-19 and it was the beginning stages of his illness. He was okay. He was driving. He had a bad car accident. He went to the hospital and he was admitted for his car accident injuries. And then his respiratory status started to deteriorate and his chest x-ray and his CAT scan looked like COVID-19. And then he passed away. Is that because of the car accident or is that because of COVID-19? I don't know. And you don't know, but we simply cannot speculate as to what other doctors are doing on death certificates if we are not there and directly involved in that patient's care. And so then you may say, well, why is it so relevant to even talk about what we don't know? Well, we can't very well go and open up the entire country or even the entire state if we don't have validated proof of what our numerator is or what our denominator is. There is still so much to be learned here. And I am not making an argument to stay with shelter-in-place orders indefinitely or for months to come. I am just entertaining the fact that we don't have all the facts and there is still so much to be learned here. And we'll talk about that a little bit more. Next, I want to talk about a study that aims to address the denominator in this issue, which is basically how many people have really had COVID-19. And I think that for what we have available at this point in time, the study that we're going to discuss was pretty good. There are some positive aspects to it, there are some flaws to it, and this exists with all medical science. I also want to talk about maybe why we can't use this study or the similar studies that have come from it to guide a state or a nation to make a very important change, just as of yet. Doesn't mean it's not coming. If the results in this study can be reproduced with some improvement in methodology and a larger sample size, then I think it's going to be very good news for us. And I want to point out that when I analyzed this study, I looked at the actual study. I did not read a news article that summarized the study. And it took a long time. And I had definitely had to recruit some help when it came to understanding the statistical analysis because it is quite complex. And I'm going to do my best in order to make it simple for you. But first and foremost, if you read the article, it will say at the top of the article in bold blue letters, this article is a preprint and has not been peer reviewed. And I'll talk about what that means. It reports new medical research that has yet to be evaluated and so should not be used to guide clinical practice. Peer review is a process in which a research study is reviewed by a team of experts in the field, some of whom may agree with the findings and some of whom who won't. And this is done in order to assure that methodology is correct, statistical analysis is correct, because numbers can be skewed, and that the conclusions from the research study are appropriate for what the results actually showed. In other words, we're not reaching too far with the results that the study came out with. And so even the authors of this study acknowledge that while their results might be promising, we cannot adjust our clinical practices in this state or in this country because of what was found. So what does it say? Well, they say that a random sampling of 3,330 people from Facebook, we'll get into that in a minute, adjusting for zip code, sex, and race and ethnicity, not their age, showed that anywhere from 2.49 to 4.16 of individuals have already had COVID-19 in Santa Clara County. And the conclusions of the study state that based on these percentages, 25 to 50 times more people have actually been infected with the virus than what current testing reveals. And if more people have truly had COVID-19, then the mortality would go down, right? Because our denominator is getting so much bigger. And if the mortality rate is coming down, then why not reopen the economy, right? Right. Let's talk about a few things. This article is definitely promising. I want it to be true, and I really hope that subsequent studies show this to be true, because that means that we get to reopen safely, and I think that is the ultimate goal for all of us. But here are some of the questions and the concerns about this study that came about when I read it. Number one, the 3,300 participants were recruited through Facebook in a 2-day period from April 3rd to April 4th. I think you can see the inherent flaws in that. Not only was it just a Facebook post, but it was shared amongst common circles. And again, we can tell on social media, we tend to follow people and read people's articles that we agree with, right? And then you have other people that are totally different than what you agree with, and it frustrates you to have that on your feed, and so you unfollow them and you don't see what they're saying. And that already has created a bias. Not only is there a sampling bias based on that, but what if you're not on Facebook? That means you're not good enough to be in the study? What if you were busy during the 2 days of recruitment and you never had a chance to participate? What if you can barely work your phone? What if you broke your phone? What if you couldn't afford internet that month? So again, this is not random sampling. And again, I agree that they had a very short amount of time. They wanted to reach a large number of people, and we all know that social media is a good way to do that. But the next study that comes out needs to not utilize social media. Number two, another sampling bias in this study was that the way in which they involved children was that if a parent consented to the study, they were able to bring one child with them. Now, given how catchy this virus is, and we know that, wouldn't the results be skewed if every single positive adult gets to bring a positive child with them? We need to have children enrolled in the study once their parents have consented, that are independent of other families. Because again, we can't have this type of sampling bias. Age, we know that age is very important when it comes to COVID-19, and the study was not adjusted for age, and we know that there are different demographics on Facebook. Some older people are not on social media. Facebook has a slightly older group of individuals in comparison to Instagram. So there's lots of sampling bias here. And I'm not saying that to put down the study, because again, they worked quickly. And like I said, social media helps to get things out quickly. Next up, the testing was done through a capillary blood draw, which is a finger stick. This is not a venipuncture that you get out of the inside of your elbow. And in clinical practice, a finger stick is very useful because it's a rapid answer to the lab that you're drawing. But anytime we get a questionable result, the first thing we do is we repeat that through an actual venipuncture, because we know that getting blood from these larger blood vessels is going to give us a more accurate assessment of what we're testing than this capillary blood draw. Now, is it feasible to do that type of blood draw in a short amount of time on more than 3,000 people? Not necessarily, but perhaps this is something to look at for the next study. Next, how valid was this test? So, it was confirmed by the manufacturer of the test against 85 positive cases and 371 negative cases. So again, it's good that this test has had some validation study. And the authors then, to their credit, also furthered that validity testing against 37 positive tests of their own at Stanford and 30 negative tests of their own. And based on this data, they determined that the test that they were using had a sensitivity of 80%, which means 20% false negatives. And in the medical world, that's actually pretty good. And a specificity of 99.5%, meaning only 0.5% false positives. That's a really good test, like better than any test out there. So it starts to make us wonder, do we not have enough validity testing when in 3 weeks' time we came out with an almost perfect test? The actual data, the raw numbers from this study were not released until today. And now they are actually making a correction that the specificity is down to 98%. And that is a little bit more realistic, but is also going to then decrease some of the percentages that we're going to talk about in just a moment. But the point in terms of getting into that really nitty gritty, and I know some of it went over your head, and I don't mean it to, but it also shows how complex this issue, and again, it's not simple multiplication and division that we're dealing with. Is this test or is this study accurate enough to put hundreds of thousands of lives at stake because of it? Is it accurate enough for an entire state of 39 million people to act upon? I don't think it is yet. Now, in this study, the total number of positive cases who have antibodies against COVID-19 was 50, 50, out of 33, I can never get this right, 3,330, which is a crude percentage of 1.5%. It's not super high, but this percentage was then weighted or adjusted to match the gender, the zip code, and the ethnic or racial distribution of Santa Clara County. And that actually increased the percentage to 2.49%. So what on earth does that even mean? What it means is that they tried their best in their random sampling to have a sample that was reflective of what exists in Santa Clara Valley, or Santa Clara County, in terms of their gender distribution, in terms of their racial or ethnic distribution, and in terms of their zip code distribution. But of course, it was not a perfect reflection of what truly exists in that county. So they statistically adjusted their percentage to match what's happening in the county. And that, in the world of statistics, is actually a permissible thing to do. And when they did that, it increased the percentage of those who have been exposed from 1.5 to 2.49. And then when they further adjusted the percentage to account for the sensitivity and specificity of the test, the percentage went up all the way to 4.16%. And when they applied this to, sorry, I gotta look at my notes because it's a lot of numbers, right? When they applied this weighted percentage to the actual population of Santa Clara County, that actually increased the number of people in Santa Clara County who could potentially have had this virus to 40 to 80,000. And they compare that to the number of positive cases that they had, which at the time was roughly 965, and they conclude that the prevalence of COVID-19 in Santa Clara Valley is 50 to 85 times higher than what current testing shows. Well, if that is in fact true, that's fantastic. if we can if we can reproduce these results on a much higher level, we're talking tens of thousands of patients with true random sampling, eliminating social media from the equation, taking children from different households, and having a higher level of validity testing, then I do believe that we would have proof that this virus is not as lethal as we once thought and is far more widespread. So I do applaud the authors for what they've done this far. It is a groundbreaking start. I'm glad that they're sharing their raw data, and we'll learn more about that when we see it today. But it's not the Empire State Building. It's just breaking ground. This was a lot of analysis, and like I said, I know some of it went over your head. It's even hard to just speak about, but I wanted to show you how much goes into a true research study, why it has to be peer-reviewed, and why facts and things that are reported in our news articles are not always as straightforward as you might think. Okay, next, let's talk about social distancing comparison, since all of us are interested in what's happening in Sweden. So Sweden has chosen not to implement social distancing orders to the extent that other neighboring European countries or the states have. Younger kids continue to go to school, and most businesses are open. But it's important to know that universities, as well as schools for older children, have actually been switched to distance learning. On April 1st, nursing home visits were actually banned from family and friends. Residents were asked to refrain from non-essential travel, keep their distance, and take personal responsibility. Gatherings of 50 people have also been banned as well. So I can't necessarily say that they are not social distancing at all, but perhaps their measures are just not as aggressive as ours. Johns Hopkins University presented some data controlled for population just 2 days ago. At the current time, Sweden has 21.6 coronavirus deaths per 100,000 people. The neighboring Scandinavian countries like Denmark, who is utilizing social distancing, has 7 per 100,000. Norway and Finland have less than 4. Denmark and Norway are actually now starting to ease the restrictions, while Finland has decided to keep it present until May 13th. Now, if we look at another European country with a similar size as Sweden, 10 million people, that took very aggressive social distancing measures, like the Czech Republic, they are actually at 2 deaths per 100,000 people. And even the Swedish health minister states that it's far too early to draw any firm conclusions as to the effectiveness of the measures in Sweden. So if the Swedish health minister is saying that, why on earth are we here in America talking about Sweden so much? To give you a frame of reference in terms of how many deaths per 100,000 the US has right now, we have 16.8 in comparison to Sweden, who has 21.6. But it's not fair to compare Sweden to the US, because Sweden is a genetically homogeneous population, and obviously the US is not. There are several other demographic factors that come into play here, but that's why I wanted to highlight what's happening in Sweden versus Denmark and Norway, which are actually genetically more similar. So most of us are going to answer that we can't compare Sweden to the US, but we can compare it to other similar Scandinavian countries. And some of you may be asking, why did Sweden even take such a stance? You know, why did they kind of hold their ground while their neighbors and the rest of the world were engaging in social distancing? And the idea was this concept of herd immunity. They felt that their people needed to get out there, get exposed to this virus, and become immune. But herd immunity is a little bit different. It is the idea that so many people are protected from the disease, either by way of having it or being vaccinated against it, so that there is very little transmission of the virus that is happening at any given point in time. And the percentage of people that need to have been exposed to the virus, either by way of actual illness or vaccine, is between 70 and 80%. What we don't know is herd immunity even an option with COVID-19? And I don't know that that question has been asked very much. In other words, are we absolutely certain that reinfection with COVID-19 is not possible? And if so, where's the proof? Because I haven't seen that yet. I have seen speculation and anecdotal data that you can get reinfected, but I have not seen proof that you cannot get reinfected. I think we need to study that a little bit more. Do we know how long the antibodies that are supposedly protective for COVID-19 remain in our system and protect us against the virus? For example, chickenpox antibodies are lifelong. But if you've actually had the virus, you run the risk of that virus reactivating in your system and you getting zoster. Whooping cough antibodies, mostly by way of vaccination, because most of us have not had whooping cough, actually wanes every 5 to 10 years, which is why you got the vaccine as a kindergartner and why our junior hires have to get it again, and why it's recommended that women who are pregnant get that vaccine with every single pregnancy so they don't spread it to their newborn. We simply don't know whether or not herd immunity exists with COVID-19, and we don't know how long those protective antibodies stay in our system. So again, there's so much we don't know. And I will tell you that I firmly believe we have to get reopening right the first time around. Singapore and Japan opened prematurely and they had to lock back down. And as you can see with the growing contention in our country, this nation is not going to go back on lockdown. When we open up, we are going to stay open regardless of what happens, because simply people will not be locked down. So why not slow down? Why not take a matter of weeks, not saying it's months, to get this right the first time rather than rushing into reopening the economy? So I just want to conclude with letting you know how humbling I think this process is. Until now, I have taken for granted all of the information that I know about simple diseases that I take care of in kids from day to day. Ear infections, asthma, allergies, etc. We have so much research on those conditions and so many evidence-based recommendations. And it wasn't until now that I realized how many decades have gone into even those simple conditions. We have so much to learn, and we are learning more and more every day. And ultimately, I think that knowledge is what's going to set us free, literally. So that's it. I hope that was helpful for you guys. Take care, and until next time.